I'm supposed to be talking. I wanted to put up a picture of some of the wonderful people, people and dogs are people too, aren't they, that we deal with in residential care because, it's all very well to say advanced care planning is wonderful and it always works, but it doesn't always work so well, does it? And just before we start, one of my favorite cartoons about advanced care planning, just so you know, I never want to live in a vegetative state dependent on some machine. If that ever happens, just unplug me, okay? I'm sure we can all recognize this. It happens on a daily basis. But in reality, we see lots of people that just don't really take to the concept of advanced care planning. And, death and dying for many people are taboo subjects. In fact, I've used it as a way to get through customs, and that's just basically to say what kind of, what do you do? I work with dying people. You're on your way. And I'm serious, it does work. Try it sometime. It really is a taboo subject for many people. Many people haven't really thought about it. And so, that's one of the reasons. A lot of people feel that it is really an incredible audacity of us to even try and plan for something like dying, which is, many people would say, we're not in charge of that. And I'm actually quite a firm believer that we really aren't in charge of who lives and who dies. Because you have seen the 20-year-olds who die from a 6-foot fall and the 96-year-olds who just don't die no matter what. So, you do see that it really is beyond human control. And so that's why many people, again, feel that this is not a responsible thing to do. And I think also planning for dying is often considered a totally foreign concept. And, people just feel like it's just not something they wish to do. And why is this? Well, distrust of the healthcare system. And I always remember a daughter who said, who held up to me the no CPR form and said to me, I've got a master's degree and I read this and this says no treatment. And, the long form with the tiny printing that you can hardly read. I told you about DNAR1 speeding it up. People get confused about things. Family conflict is another matter. The out-of-town son who feels very guilty, I think you talked about that one, who says you can't give up on mom, we've got to keep going. Family just feels, I can recall people arguing over the dead body of their sibling. You were never there for her, Language barriers make a huge difference. It's always good to have an interpreter, a professional interpreter, not the family, because I often find family just can't possibly say what needs to be said. And then I do mention metaphor barrier, and I didn't really realize this till I was working with a family where the healthcare providers really had try and have those conversations with family, but they were using the letting go metaphor, and to the family that equaled abandonment. And so that didn't work for them, and sometimes we need to have a different set of analogies and ways of talking about things. So I was looking at this article, which was based on a bunch of interviews and review of the literature and so on, about recommendations where people are saying, I don't want to plan. And what you really need to do is develop trust over time and hope the hell that nothing happens before you get a chance to establish trust. Develop cultural awareness and respect for differing values and orientations. In other words, some people will say, every little bit of life has value, and as long as my loved one has some life, I want to value that. And the concept of quality of life is not as important as long as there is some life. We really need to promote patients and families as partners in advanced care planning too, so that it's, because oftentimes I feel like families feel we're forcing something on them, or we just want to get them out of the hospital, usually acute care, or we just want to, get them dealt with, instead of understanding that we're working together as a team. And then I think practical support through the illness wins trust. So, suggestions, if you're running up against barriers for people who just can't go there, they don't want to do goals of care discussions, they don't come with an advanced care plan, I find Kleinman's questions very helpful, and you can Google them and come up with them, but it was basically a physician who's a medical anthropologist who looked at asking people these questions to name their problem. And I specifically remember a meeting with a family who was still sending their loved one with advanced dementia to acute care to receive treatment, and sitting down with them with an interpreter and saying, what do you think is going on? And they told me that their father was dying of sadness, because there was actually there had been a murder in the family, and they had tried to say that this was not a murder, it was an accidental death, and there was lots of terrible grief, and they felt their father was dying of grief, not of dementia. Although they knew he had dementia, but again, I don't think they understood the progression of that disease. And so it was very helpful for us to really understand this, that they were not willing to give up because they felt he was dying from grief. So these questions can be very useful. And then I tend to add on 2 more questions, which I did pose to Kleinman once when I nabbed him at a conference. And that was, what do you hope for in the future? And what would be a good outcome for you or for this person, right? Because oftentimes we realized with this family that we were totally on the same page, that we both wanted. They knew that he was going to die someday and that it would be quite soon. But it was acknowledging this and removing the myths and the unhelpful metaphors that really helped. I often think, we're taught that, the public is taught that medicine knows all, can test all, can see all, and yet, as you all know, we often feel quite inadequately prepared to tell people about prognosis, to tell them about how it's going to go and what's going to happen. And so people, will get very distressed when we're uncertain. So you need to really learn to convey uncertainty with great confidence. And this is challenging to do, but I think to have some phrases like, we're not certain how long a person with this kind of illness will live, What we are certain about is that it will be an up and down course, so you learn to convey this with some kind of certainty and acknowledge how difficult this is for people. But all the time preparing them and all of the care team being on the same page. And we need to help them live with this uncertainty too, because people find that very challenging. And I recommend an article there that you can look up. The other thing is an excellent article that talks about balancing a patient's autonomy with a healthcare provider responsibility. Because if we just say to people, what do you want us to do? This may be their first experience with their loved one being sick or with dying, and gosh, we have way more experience than they do. It's our obligation to help guide them through this, because really to just say, well, it's up to you, and I can understand people saying that because the courts, things get to court, and isn't it easier just to say, what do you want to do? But oftentimes I feel like then it leads to the kind of raving relatives who are kind of in control of the situation, and it's going to hell in a handbasket, and you need to come along and sort of drag them off the ropes in the high pinnacle of the sinking ship and say, just a minute here, someone needs to help out. So I would encourage you to make suggestions. Say to people, would you like me to make a recommendation? Would it help you if I talk to you about what I think might be best, if I understand, this is what I understand about your mom, what's important to her, this is what I understand about the medical situation, and here's how I might approach it. So thank you very much.